Hello, everyone. Thanks for joining us. We're about to get started now. I want to welcome you to today's webinar, Introduction to Community Inclusion. I'm Nathaniel Counts, Policy Associate at Mental Health America, and I'd like to welcome all of you. We're so happy to have you today. We're delighted to have a diversity of participants, including those from Mental Health America affiliates, community and peer provider organizations, government entities, academic institutions, and behavioral health managed care organizations. Before turning it over to our main presenter, I would like to first discuss our project and why we have invited you to this webinar. Second, introduce the sponsoring organizations. And finally, third, introduce our main presenter. First, today's webinar, while entitled An Introduction to Community Inclusion, will offer an in-depth understanding of community inclusion principles and include examples of community inclusion practices. It is a part of a joint project between Mental Health America, the Temple University Collaborative on Community Inclusion, and the Association for Behavioral Health and Wellness, to promote community inclusion in service provision and policy. Over the next few years, we will be working together to create tools that help stakeholders evaluate and promote policies that help individuals with psychiatric disabilities achieve their recovery goals and fully participate in the communities of their choosing. For all of you listening, you have been invited to participate in this webinar because of the crucial role you play in guiding community policies, practices, and attitudes towards individuals with mental health needs. Listeners include state and county mental health agencies and other members of government, behavioral managed care organizations, providers, advocates, and academics. We hope that you will all lend your expertise and your leadership to our project as we identify successes, barriers, and ways forward for systemic change and community inclusion. We will use your input throughout our project as we design tools that make the principles of community inclusion immediately accessible to those interested in promoting it within their communities. Your engagement is deeply appreciated. Second, please allow me to introduce today's sponsoring organizations. So first we have Mental Health America. With more than 220 affiliates nationwide, at 105 years old, it is the country's oldest advocacy organization dedicated to helping individuals lead more mentally healthy lives. Many of our affiliates are also service providers and have been at the forefront of developing, piloting, and implementing innovative recovery services. The Temple University Collaborative on Community Inclusion of Individuals with Psychiatric Disabilities is a national rehabilitation research and training center funded by the National Institute on Disability and Rehabilitation Research, NIDR. Their state-of-the-art research and cutting-edge knowledge translation activities broaden understanding of community integration and improve opportunities for individuals with psychiatric disabilities to participate more fully in community life. The Association for Behavioral Health and Wellness is the national voice for specialty behavioral health and wellness companies. ABHW member companies provide specialty services to treat mental health, substance use, and other behavioral needs that impact health. ABHW supports effective federal, state, and accrediting organization policies that ensure specialty behavioral health organizations can continue to increase quality, manage costs, and promote wellness for nearly 125 million people that they serve. Behavioral health managed care organizations both pioneered applications and proved the efficacy of community support programs, especially peer supports. They paved the way for the creation of funding streams that have promoted institutional and systems change. They have helped to make peer support services an integral part of the continuum of care for behavioral health conditions. With Mental Health America, the Temple Collaborative, and ABHW collaborating with state and county government, care management, providers, and academics, we hope to affect change and improve the community inclusion of individuals with mental health needs. Before I introduce today's speaker, please allow me to make a couple of housekeeping announcements. Today's webinar is being recorded. In a few weeks, this recording and the slides will be available on MHA's website for download. You're also welcome to type questions into the chat box on your screen. You'll see it in the bottom left-hand corner, and we'll be excited to answer these after the main presentation. We also invite your input throughout our project, and at the beginning in a survey we will be presenting to you at the end of the main presentation. So please, as we go, put your type questions in the chat box, and we will answer them at the end of the main presentation. Now I'd like to introduce to you Richard C. Barron, MA. Richard Barron is a researcher and trainer in the mental health field at Temple University. He is currently the Director of Knowledge Translation for the Temple Collaborative on Community Inclusion of Individuals with Psychiatric Disabilities, funded by the National Institute on Disability and Rehabilitation Research. The collaborative focuses on improving the capacity of mental health policies, programs, and practices to assist individuals with mental health conditions to participate more fully in community life, and includes an array of research initiatives and training and technical assistance activities. Mr. Barron is also the co-director of the recently established College of Recovery and Community Inclusion, an online curriculum for direct service personnel in the community mental health field. Previously, Mr. Barron was the director of the Pew Charitable Trust grant-making program for health and human services agencies serving adults in 5-county Philadelphia metropolitan area. And prior to that, served for 25 years as the executive director of the Matrix Research Institute in Philadelphia, where his work as principal investigator and project director on 24 federally funded research and training programs focused on employment for people with mental health conditions. Mr. Barron is also the recipient of 2 NIDER Switzer independent research fellowships, both also focusing on strategies to expand competitive employment opportunities for people with mental health conditions. We're so glad we could have you here today, Mr. Barron, and now we want to turn it over to you to tell us about community inclusion. In order to unmute yourself, please press *7 now. Mr. Barron?
Unmute himself.
Yeah, you don't need to do that. You unmute
Or
him.
unmuting. Can you hear me?
Yep.
The conference has been muted.
Mr. Barron?
Mr. Barron, if you could unmute by pressing *7.
Can you hear me now?
Yes.
All righty. All right. Sorry for that confusion. Thank you, Nathaniel. I'm pleased to be here. I'm impressed with your introduction of me. I sound a little bit more important than I actually am, and a lot older than I like to think I am. I'm here at the Temple Collaborative on Community Inclusion in Philadelphia, where we've been engaged in a wide range of research and training activities, as Nathaniel points out, that focus on the policies, programs, and practices that promote community inclusion. And we're very happy to be working on the project with MHA and ABHW that is designed to broaden the base of people who are interested in and active about these issues. Special thanks to Debbie Plotnick, who unfortunately can't be here, for her leadership in making this project and this particular webinar possible, and certainly to all of you for having the interest and enthusiasm to join us. I'm going to be talking today about community inclusion and giving you a broad introduction. I think we can broadly think of it as a refocusing of mental health services and supports to help more people with serious mental health conditions to participate in everyday life in the community. And doing that by balancing our current array of in-house programs. And many of our in-house programs are attempting to prepare people for community life or are ultimately often providing a substitute for engagement in the community, and moving from that to a greater emphasis on programs that provide the supports people need to be engaged in the community, and to move from what some people have called community presence to community participation. So we're talking about what mental health programs do and what they spend money on, and trying to make a considered and productive shift in the emphasis from in-house services to community-focused services. I wanted to talk a little bit, tell you a little bit about myself, but Nathaniel already has. But this is where you can reach me. That's the phone number and the email address. And I would recommend that you turn to our website, the tucollaborative.org website, where you can learn more about our past research and our current research. You can learn more about the wide array of training and technical assistance and dissemination activities we make available to people. These are all now called knowledge translation activities. But I would especially recommend that you go through the part of the website devoted to resources, where there are a few hundred monographs and journal articles and manuals and sets of recommendations about the topic of community inclusion. We're here at Temple University in the Department of Rehabilitation Sciences, where Dr. Mark Salzer is the chair of the department, but also the director of the NIDRR-funded Research and Training Center that funds this wide array of research and training activities. Our partners in the operation of the Research and Training Center are the National Mental Health Consumer Self-Help Clearinghouse, one of the nation's leading consumer-run empowerment centers, and has been for over 20 years, and of course Mental Health America. And we're delighted to be working with them on this effort to focus on these issues, how they impact service delivery, and also redefine the outcomes we are looking for when we assess how well we're doing in community mental health. I'm going to start with a more formal definition of community inclusion. Dr. Salzer defines it, and has for some years, as the opportunity to live in the community and be valued for one's uniqueness and abilities like everyone else. I want to talk about very briefly each of the three elements of that definition because we are talking, first of all, about opportunities. We believe that the field has a long tradition of assuming a level of chronicity and stability and lack of progress for people, and we want to make sure that we are offering as many opportunities as we can to each individual with serious mental health conditions to engage more fully in the community. And we do that because we believe not only in their uniqueness but also in their abilities. We believe that if we offer people the opportunities, they will in fact be able often to take advantage of those and move toward a greater level of community participation, which means behaving like everyone else. We're talking about the full array of life domains in which people can and should be active, and we're talking about helping people to move beyond what the sociologist Susan Estroff many years ago characterized as the subculture of psychiatric disability, the increasing number of people who spend their days living within the mental health system, living in housing and going to workshops and participating in social activities and skill development programs, but always with and among other people with psychiatric disabilities, and helping people to go further. There are some other definitions that you might find useful. I like the one at the top of this particular page, because I find myself often talking about community inclusion being the process of helping people to move beyond the all too warm embrace of mental health systems. You sort of know what I mean. With the best of intentions and with some real passion, we go out of our way in consumer-operated programs and in partial hospitalization programs and in a whole variety of rehabilitation and clinical programs to create a warm and supportive environment for people who have serious mental health conditions. And people, we feel, often get, and the evidence seems to indicate that they often get very comfortable in those systems and begin to define themselves and their life goals in terms of their effectiveness and utilization of mental health systems when we think we need to push beyond our comfort levels, ours as staff and theirs as consumers, and begin to talk about activity in the community. There are a number of questions about the relationship between community inclusion and recovery, and if we simplify what recovery is talking about and the extraordinary importance of the recovery movement, frequently people are talking about hope and they are talking about empowerment, but these are not ends in and of themselves. These are tools, we think, that people use to re-engage in community life. Another way to look at community inclusion comes from an English group called the Institute on Social Inclusion out of the United Kingdom. And they talk about the need to move from segregated to mainstream services. The quote there is, to promote inclusion, we need pathways from segregated service provision into mainstream services, groups or activities solely for persons with mental health problems may reinforce segregation unless they are part of a supported pathway into mainstream services accessed by everyone. And I like that notion of a supported pathway as good a definition of what we're about in framing policies, programs, and practices that promote community inclusion. I guess you could ask, why is this emphasis that we place on it important? Our research and the research of others does indicate that large numbers of people are fairly well isolated from everyday life, despite their presence in the community. We know that 90% of mental health sponsored housing clusters people in poor communities. We continue to know that a staggering 75 to 85% of those with serious mental illnesses are unemployed at any one point in time. And you think about what that means in terms of community inclusion, and you can see how separated out people are just on that data alone. If you look at socialization, and you look at the research that compares the social networks of people with mental illnesses to the social networks of people without mental illnesses, people with mental illness report 50% fewer people in their social networks than do others. And of that 50%, 50% are people who work for the mental health system, who they are counting as their social network. So you can see that they are far more isolated, many people, than others. Mothers with mental illnesses are 3 times more likely to lose child custody cases simply because they've been defined as a person with mental illness. Majority of states still restrict to some degree the right to vote, to serve on juries, or hold public office because of defined mental illness. And we have a great deal of research now about the degree to which college students with psychiatric disabilities wind up being less involved with faculty, less involved in student life, and experiencing the same kind of isolation that others do. I suppose it's a good question of why this is so. We think it's so because there's been a generation or more of a slow accumulation of convictions, partially on the part of clinicians, partially on the part of counselors, partially on the part of consumers themselves, and partially on the part of the communities in which people have been living these last 30 or 40 years, that people, to be a little glib about it, shouldn't, wouldn't, and couldn't manage participation in the community, when in fact the research is overwhelmingly telling us that's not so. In our discussions with consumers, for instance, we hear frequently how often they have been told that they should not seek to participate in community life. They're either not ready for it yet, or will never be able to hold a job or sustain a marriage or engage in any of a wide variety of other activities. And mostly because the pressure, the stress of it will be too great. They will become sick again. And the most important thing is to protect stability. The research overwhelmingly indicates that people who are productively engaged in the community and working, people who are actively parenting, people who are engaged in social activities, people who are participating in the full array of the opportunities provided by religious organizations, in fact, are better off just in terms of symptoms and certainly in terms of satisfaction. People should participate in community life. We hear an awful lot that people, consumers are told, people tell us that consumers tell them they don't want to participate. If you ask somebody if they want to work, they say no. If they want to make some new friends, they say no. The reality is that all the surveys of consumers tend to indicate that people are interested and very interested in being active, and most report the same 3 goals. They want a decent home of their own, a good job, and a few friends. Those don't seem like overwhelmingly difficult things for us to provide, but for an alarming number of people, we're still falling short on that end. And then the question might be asked, even though people should and would, can they do it? Well, I think we have the beginnings of a new research base based on the supported approaches to employment and education and socialization, that if we move quickly and we provide the supports that people need, in fact, people can participate. It seems to us, in fact, that every time we go beyond our own comfort level and offer opportunities to people, a new percentage of the people who have had limited lives take advantage of those opportunities and begin to move toward community engagement. So some examples of that. I mean, it wasn't that much long ago, or I guess a generation ago, when people said people with serious mental illnesses can't live outside of state hospitals, and then couldn't live outside of boarding homes and group homes in the community. And yet, Housing First initiatives in a wide variety of settings are beginning to tell us that people can and should and benefit from living independently. But we think we might even want to go beyond those mental health sponsored Housing First initiatives and start talking with community development agencies in the mainstream and talking about how we can access the housing that they develop. And we think we can go further and begin to take advantage of the low-income home ownership program sponsored by states and the federal government and help the people that we serve become homeowners. It wasn't long ago that we presumed, and I can't tell you how many consumers have told me they were told by their psychiatrist they would never be able to work, and yet they can. Now we're at a point where we need to go beyond the kinds of training programs that we have traditionally provided within the mental health system and begin looking at mainstream workforce development training programs. I was saying to Nathaniel the other day, I get in arguments all the time with agencies that run their own computer labs and teaching people to use computers, which is a great idea. My question to them is, why aren't we using the computer training programs within the broader community and helping people to take advantage of and succeed in those programs rather than teaching them within that segregated setting? Same thing applies to the programs who are working on social skills. What we need to do is begin to get people into social and recreational activities in the community itself. Sometimes drawing community mentors from the agencies themselves. We had an instance not too long ago where someone in a psychiatric rehabilitation program had 3 or 4 women who wanted to learn to knit, went to a local yarn store, asked the lady who ran the yarn store if she would come into the agency and do a once-a-week class, and God bless her, she said, "No, I have no time for that sort of activity. Why don't you just have those 3 women join the Thursday night class I run here at the store and take it out of the psychiatric setting and into the mainstream?" The same thing applies to sports teams and civic groups. Let's get people and support people in being active in the community. The same thing is true with education. How do we begin to help people take advantage of community colleges and career colleges and do it with the kind of supported education models that exist across the country? With health and wellness, how do we get people to make better use of community health clinics? Instead of running exercise programs within our services, why don't we help people get gym memberships or join the local Y and participate in their health and wellness programs? Same thing is true with regard to religion. We did a survey maybe 3 or 4 years ago of consumers here in Montgomery County, Pennsylvania, a suburb of Philadelphia, and almost every one of the consumer surveys said they did attend church on Sunday mornings. But when we looked closer, that's all that they did. They got up, they put on their best clothes, they went to church, they came home after services. What we're really talking about now is trying to provide the supports people need to be more engaged in the full life of the congregation, to take advantage not only of the faith aspects of religious life, but also the fellowship aspects of religious life, which is so important to so many people. How do we help people reestablish normalized roles within existing family settings? In one of our projects, well, 2 stories. In one of our projects, someone asked for some support, financial and individual support, in throwing a baby shower for her sister. Sort of redefining her role not as simply the person who needs support from the rest of the family, but of someone who can contribute to the rest of the family. There's a program out in the Midwest where a wealthy woman wrote to her local community mental health center and said, I so appreciate the fact that you are there to support my son. He's been coming for 20 years. I don't know what we would have done without your program. My question is, why is he still coming there? And they have begun to build a whole range of programs that help people move away from the center and into community activities. Sooner or later, we are going to confront the issue of intimacy and the roles that we need to play in helping people think about and succeed in romantic and sexual relationships and marriage and child rearing, living more like everyone else. I'll take a moment to say that if we do all of these things, if we do begin to help people more fully engage in community life, we're going to need to have a way to measure how we're doing, both at the individual and the aggregate level. One of the measures we've come up with here at Temple is the Temple University Community Participation Measure. You can find more about this on our on our website rather. But I've provided a couple pages of it here in which a counselor can sit down, a peer counselor, a clinician, a case manager, and work through the following form, in each instance asking, how many times during the last 30 days have you participated in the following activities? Do you do this activity enough or not enough or too much for yourself? And is this activity important to you? If you go through the scale, you can see we're asking about grocery shopping and religious participation in movies and recreational programs and running errands and going to the library, and a whole wide range of activities that engage people in community life and give them the opportunity to be with other people. The advantage is you can use this scale or others like it on an individual basis to help people figure out for themselves what it is they like, what it is they want to do more of, how important that is, set some priorities for themselves, and then if you do it repeatedly, let's say every 6 months, give both the program and the individual a sense of the kind of progress they're making while setting new goals. If you do it in an aggregate basis, that if you look at the answers to these questions across the wide array of individuals being served by an individual agency, you get a sense of how well the agency is doing, but you also have the opportunity to see whether there are some domains of life that people are all expressing a sustained interest in improving their participation in, and it gives you a way as an agency to focus some of your initiatives. If you're going to do this, then we need to begin talking about some of the principles that drive community inclusion. The first is to accept that community inclusion is a right, and you will see, I think, over the next few years, a continuing emphasis on moving from federal and state requirements for least restrictive care to most inclusive care, not simply moving people out of hospitals and out of group homes, but into settings in which they are actively engaged in community life, and to do it now. Second principle is to focus on a wide array of roles. All the domains of life that I've been talking about are things that we need to offer opportunities in to give people a chance to see what it is they want to do and what direction they want their lives to take. But we also consider it important to talk about the responsibilities that individual consumers have for their own community inclusion. There's a good deal of research on social networks, and I think community inclusion is in part a business of helping people to create social networks for themselves. Yet the research indicates that the strongest social networks are reciprocal. That is, in which one person makes a contribution to the group and expects support when he or she needs it. We've built a system of to use the phrase, circles of support, in which we try to provide a whole array of supports and services to people, and don't begin to talk to them about the supports and services they're going to need to provide if they're going to be a full family member, if they're going to be seen as an equal in a work setting, if they're going to participate in the fellowship aspects of community life, if they're going to be in a college setting with other students. What is it that they need to be able to do for other people in order to build that social network? even while they are relying on the network from support as well. Fourth principle we talk about, and I realize I'm going fairly fast, is the issue of choice. If we're going to pursue this, the decision about what to pursue and how fast to pursue it is really the individual's choice. We need to begin working with people as individuals about what they want to do and how fast they want to move, and which community activities they want to participate in, as well as how open they want us or themselves to be when they're in the community about their mental illness and the nature of their mental illness. But there are some barriers, fifth, that need to be addressed. Certainly, attitudinal barriers need to be addressed. I think we have a large number of recipients of services, of program participants who like us, who like the services we provide, and are reluctant or frightened or concerned about moving on. We need to grapple with that in effective ways with people. And to do that, we need counselors who are not sharing the same concerns and reinforcing them. And then we need to begin to work with communities one by one, with individuals in the community to change their attitudes. But clearly, we need as well to be talking about funding. We're not talking necessarily about new programs and new resources. We're talking about shifting the resources that we have, of shifting what we do and what we spend money on to accomplish those ends and the outcomes we are looking for. And part of that, I think, will ultimately resolve itself if we can begin to redefine community inclusion as a medically necessary services. But those are significant barriers to be addressed. But I also want to be clear that we are talking about support. We're not talking about closing down all of the supportive programs we provide in-house and saying to people, find these supports and services in the community on your own. We're talking about rebalancing that division between in-house services and community support and providing the individualized support that each person needs to engage in community life in the ways that they want to. If we're going to do this, treatment personnel and case managers need to be supportive of it. Rehabilitation programs have to focus on the community. We can draw on the supports of families and friends and neighbors, and certainly the peer movement, both just the person-to-person support of people being together, but also the roles that we can define for peer specialists should certainly be emphasizing the issues of community inclusion and going beyond the psychiatric milieu. But it is also clear to me from the examples we have from around the country that if we turn to community organizations, if we turn to employers and educators in the community, if we turn to religious leaders and family members and recreational programs, and we talk to them with the client's permission about, I have somebody who wants to join your group, can you provide some support for them? Not for a program, not for 12 people, but for one or two people who are interested in participating in the activity you run. I think we will find people. We heard from a group here near Philadelphia in touch with the Mennonite Church, a very socially active group. They found they had 3 or 4 people from a local group home participating in services and being disruptive of services. And rather finding a way to exclude these people, they went to their social affairs committee and they got 3 or 4 individual volunteers. Each person called somebody from this group of clients and said, I've seen you're new to the church. I'd like to meet you on Sunday morning and sit with you. We can take a cigarette break together, and welcomed them in and facilitated their participation. And it worked just wonderfully. I think we need more reaching out to community groups like that, and finding the people who will actually help out. So this is my little joke here. I know these kinds of changes are difficult for us all to consider. There are 4 well-defined strategies to avoid change. One is we already do this. I think if we did a good program audit of how many people are engaged in community activities with our support as a system, we'd find we're not doing it as well as we could. The notion that consumers are already satisfied with our in-house programs. There was a program in California I talked to that did an annual survey of consumers, and the consumers always said, "We love the program. We love this program. We love the activities at the agency. We love going out in the van and going to the ball game and picnics and going to the movies together. It's all wonderful." And they've done this for many years. And I think we're all familiar with those scales. And somebody on the staff said, well, why don't we ask them as well what else they would like? And in the new year, they said, is there something we're not doing for you? And people wrote back, we love the program, we love all these activities, but to tell you the truth, we'd rather be working. And they began to revise their program to meet this expressed need for actual engagement in the economic life of their community, in competitive employment. We hear, again, that we have no resources to expand these supports. We're not talking about new resources. We're talking about shifting those dollars, redefining what it is staff does, and whose responsibilities it are. It will be in the future to help people move into the community. And, of course, we hear that the community is unwilling, and yet I think in a lot of areas where communities are resistant, we are finding that it's not the new round of public education programs that makes a difference. It's really connecting one person with another person that they would ordinarily avoid, and facilitating and supporting that connection. Even if it's only meeting them before church and sitting with them a few times and introducing them around. Even if it's only saying, sure, somebody can join us to play a round of golf. Even if it's only this one-at-a-time effort to connect people with serious mental illness with members of the community, I think over time our best bet is to build on those individual connections and make that change real. So there are some key questions that I know Debbie and Nathaniel are going to be asking you all about. How do we shift the roles of staff to focus on facilitating community engagement rather than running in-house programs? How do we reshape programs to de-emphasize in-house activities and strengthen individual connections? But also, what policies need to change? How do we change the contracts between counties and states and behavioral health care companies? How do we change the expectations? How do we measure outcomes that are really meaningful, that focus on community inclusion, rather than just rates of hospitalization? And can we ultimately begin to prove that if we move in this direction, there will be some significant cost savings for everybody involved? Because if we don't begin to do this, and this is the last part of what I want to talk about, it is my belief that we are in danger of losing another generation of individuals with psychiatric disabilities to a lifetime outside of the mainstream of community activities, unless we act now in all of our practices, programs, and policies to promote pathways to community inclusion. I think there's a real danger of losing this next generation. And I think we have to find ways to take the challenge seriously and accept community inclusion as perhaps a new generation of services that we need to grow toward and grow toward together. The last thing I'll say is certainly for more of this, certainly look at our website. You have my email address. You have my phone number. I'm happy to talk with people at any length and on any of these topics to promote this, and really appreciate the interest you've displayed in just joining us for this session. And Nathaniel, I'm going to turn it back to you.
Thank you so much. At this juncture, I was hoping to spend a few moments on questions, if that's okay.
Sure.
And so now would be a great time to, if you have any additional questions, we have 3 so far, to type them in the chat box. And we'll try to get to as many as we can within the next 10 minutes or so before I wrap up. And so, Mr. Barron, if I could ask you the first one.
Oh, I think you can call me Rick, but thanks.
Rick? So the first question is, systemic barriers make it difficult for those with severe mental illness to risk losing their benefits. i.e. Medicaid. How can these be addressed so that people can be supported while trying to find full-time employment?
Well, I've got a long answer to that. I think certainly this one area of employment is one that I'm particularly obsessive about, and the question is a good question. I think, in fact, there are a couple of things we need to begin thinking about. First is that the myth of the loss of Social Security benefits is much more powerful than the reality. Social Security has changed and continues to change, and there are many ways that people can begin to work, without losing any benefits at all, and there are many, although they are complicated ways, for people not so much to play the system, but to use the system of work incentives that are built in. You need expert advice on how to do this. You need to be able to calm consumer and family concerns about this. I don't think there are probably that many people who are going to jump to full-time employment, but people can begin to work and see the benefits of work without running large financial risks until they feel strong enough to go toward that full-time job and understand the risks involved. Lots of people have, but I understand, you're absolutely right, the fear of this I think is larger than the reality, and we need real expertise and take advantage of the kinds of counseling that is available in a lot of settings. It's also true that many states now have workers with disability low-cost health care insurance for people with disabilities who are working. These are vastly underutilized programs that people need to begin to take better advantage of when they move into full-time employment. But I think it is also a problem in terms of the kinds of jobs we have focused on. To the degree that we continue to hold everybody at entry-level kinds of jobs that are traditionally poorly paid and with very poor benefits, we run the risk of keeping people out of competitive employment altogether because it doesn't pay in the long run. Now, entry-level jobs are the right jobs for a lot of people and the right jobs for some people moving toward better jobs. But there are some people, a significant portion, who can be helped with training and support to move into competitive employment at better jobs. We need to refocus some portion of our work programs on those better jobs so that the economic benefits of full-time work really offer a challenge to what will forever be a poverty-level existence on Social Security. If we can offer jobs that offer better than poverty-level wages, I think we'll see people increasingly willing to take up that challenge.
Thank you so much. I was hoping, we have a quick question, which is, I was hoping you could remind everyone of how to get a copy of the Community Inclusion Scale.
If you go onto our website and look under resources, you will find a couple of articles and references to it. And if you can't quite find it, email me and I will send a copy of the scale to you.
Great. And then we have several sort of linked questions, so I was hoping you could answer them as a unit, which is, it's asked, what can be done to change mindsets of predominant cultures, especially in communities that believe separate but equal is good for the for the common good? And then we have sort of similarly, what would be a good way to raise awareness about the importance of community inclusion?
Well, and this is partially one of the last things that I was saying. I don't believe much more, and I've done a lot of community education work. I don't believe in broad scale. I don't believe the sole answer is in broad scale community education programs. I believe the answer is in making individual linkages between people and asking people if they will support someone. Just one person. I think if you go to a recreational program, it is one thing to say, will you, can we have a team of people with psychiatric disabilities play in your baseball league? You're going to get a no. If you go and you say, I've got one guy who loves to play second base, is there a place for him on your team? And is there someone else on the team who will at least reach out to him, give him a phone call, talk to him, introduce him around? Is there a coach, a junior coach, who will facilitate making him more comfortable, then I think we've one, provided that opportunity for the individual, and we begin to change the mindset of the individuals, and just the individuals that second baseman comes in contact with. So that the next time the discussion of mental illness comes in, they have a reference point of someone they know and potentially at least like a little bit, and even more potentially someone of whom they are not frightened because they've had that individualized contact. I think if we build more of those relationships and then begin to bring those people who've had those experiences together, we've got a much more powerful public education activity underway than a broad-scale public education campaign. And I think that will work.
Great. And so we have a sort of related question, which is one person's wondering, what are the resources available that exist, I guess, at the moment to help move community inclusion forward? For example, what has Temple Collaborative been working on?
Well, and I think that's going to be a big issue because we're talking about financial resources, I presume. I think we need to begin to look at our programs. I know Dr. Sulzer is very insistent that we have the capacity within our programs to move in this direction if we're willing to give up some of the other activities, and particularly those group-focused activities that are not proving very productive at moving people into community life, and take those resources in terms of staff roles and staff time and begin to focus on individuals and what they want to do in the community. I also think we can begin to look toward philanthropic sources to get us started in that direction. And ultimately, I think we have to begin to talk with funders about seeing this as a medically necessary service and seeing some effort to measure how we're doing as one measure of the effectiveness of an agency that warrants continued funding. It is a complex public policy issue because so much of our money is targeted. I've talked to a lot of places where they say, I'd love to move in this direction, but I'm held accountable for a daily census in my programs. And so I've got to get 40 people a day into my programs, or 120 people, to spend the whole day there to get in the money to keep the program open and operating, and I don't have another dime. We need to begin to say to funders, let's talk about using those dollars in new ways.
Great. And then we have one interesting question I wanted to bring up is someone asked, how can community inclusion be developed for individuals who have a history of sex offending, fire setting, et cetera?
That is a tough question. Well, I think it partially depends on your assessment of how much this is a historical problem that's not likely to be repeated, how much of it is a current problem. We have one of the documents on the website that we have that my colleague Bill Burns-Lynch put together for us is on managing risk. And in thinking about, and almost any level of community inclusion probably entails some measure of risk. Certainly consumers feel exposed and vulnerable. Their families are often reluctant to have them engage in community life, and communities themselves are quite worried, and counselors are worried, and so forth. What we can do is two broad strategies outlined in the document. Say, one, we can assess those risks and do what we can ahead of time to ameliorate those things. So what is it we're concerned about with a fire setter, and how do we structure his engagement in the community to minimize the opportunities that he will set fires? And then what do we do in the case of a crisis? So that at least we go in not saying this guy is a fire setter or a sex offender, and so needs to be isolated from the community, but what's the level of risk involved here? What's the nature of that risk? How likely is it? What do we need to do as he moves into the community or she moves into the community to minimize the likelihood that that is going to develop as a problem? And if we can find ways to ameliorate those problems, to give that person the same opportunity as everybody else, and to stop. I mean, what we see happening a lot across the whole spectrum of people with emotional problems, is that we make this peremptory judgment that people cannot, that the risks are too great, when in fact the evidence is that the vast majority of people are both eager to and capable of participating in the community, both to their benefit and to the strengthening of community.
Thank you so much. I'd like to direct everyone to the website on the screen. The Temple Collaborative really has a lot of amazing resources on community inclusion. I see a lot of you have asked a lot of really great questions, and unfortunately, due to time constraints, we're going to have to move on now. But I hope that you will follow up with me. You'll see my, at the end, I'll put my contact information up, and I can help answer more of your great questions. I just want to finish out now with a survey for all of you, because this is an ongoing project. And we would like to invite your continued collaboration. So as I explained at the beginning, the Temple University Collaborative is working with the Association for Behavioral Health and Wellness and Mental Health America to find innovative ways to promote community inclusion. It's a long-term dynamic project, and it's only just beginning. And we hope that you'll continue to work with us throughout the project to change the culture of organizations and communities and make community inclusion for individuals' mental health needs a reality. And so to start, we hope that you'll share your thoughts with us on a brief survey. And now I'm going to try to include the link in the chat window. Survey link. And so this should be a link to a brief survey for you. And we will also be sending it out by email to follow up. And as a quick aside for those of you in the Association for Behavioral Health and Wellness, we have a special survey for you that will be available in the chat window shortly, and which will also be sent to you by email. This survey is designed to help facilitate the creation of a vision statement of where behavioral health managed care organizations see community inclusion moving in the future. BHMCOs have consistently led the way in innovation and systemic change in mental health, being among the first to integrate the recovery model into practice, utilize peer support throughout the continuum of care, and support integrated employment, education, and housing. And we're hoping to lean on your experience in furthering a system-wide transition towards community inclusion. Please take a moment to fill out the survey available in the chat window and forward to you by ABHW, and let us know about your vision for community inclusion. So let me drop that link in the chat window now. One moment. Okay, great. And so I just want to run through the survey really quickly. And so I just asked, this is for the general survey, what organization do you represent? Could you share with us some examples you have seen of the way in which your organization or your community is currently promoting community inclusion? Could you share with us some examples of barriers your organization or your community faces in promoting community inclusion? What do you see as a next step to helping your organization or your community promote community inclusion? Is there a question we should be asking that we have not, or something that we have left out of the conversation? And I wanted to end by saying, please do not hesitate to contact me. I want to thank you all so much for your time. We'll be sending out a brief summary of the responses of the survey to all participants. And we won't be mentioning organizations or individuals, but just looking at the common themes that emerge across the responses. And anytime, please contact me with the additional questions you may have. And we appreciate your engagement with the project, and we look forward to working with you in the future.
And certainly feel free to contact us here at Temple with any questions you have, either about what's available on the website or any of the other questions that didn't get answered today.
And someone just shared an excellent question. Is the survey just for the folks on the webinar? No, we would love, for the general survey, everyone, the more information, the better as we go forward and create tools for promoting community inclusion. And for all members of ABHW not currently on the call, we would love for the second form to be shared. And we really appreciate all of your engagement. Thank you so much for your time. Thank you so much, Mr. Barron, for joining us as well. We really appreciate it.
Thank you, Mr. Counts.
Have a great day.
Thank you all.